Welcome back, guys. This is our second lecture on the part of renal disease, and in this case, we'll be looking at chronic kidney disease. So, chronic kidney disease, we are saying that here we have a progressive loss of kidney function, resulting in a decline in glomerular filtration rate, retention of urea and other nitrogenous wastes, and interrupted regulation of extracellular fluid volume, and electrolytes. We're saying that in most of the instances, you'll find this process is irreversible. We're saying that chronic kidney disease may be staged based on the cause, glomerular filtration rate, and degree of albuminuria. We are saying that these patients might not even show the signs and symptoms until 75% of glomerular filtration capacity has been lost. So this process is normally fatal and it requires treatment. So that's why we can do dialysis or kidney transplantation. Saying that this is the 9th leading cause of death in the United States. Prevalence of CKD in sub-Saharan Africa is estimated to be around 14%. In Kenya, it is estimated at 4%. Chronic kidney disease is also referred to as chronic renal failure. Stages. We're saying that CKD is defined as a kidney abnormality in terms of structure or function, and it has to be present for at least 3 months and have impacted the patient's health. The staging, as we have said, is based on the cause, on the glomerular filtration rate, and on the glomerular filtration rate we have how many stages? 5 stages. So we have G1 to G5. Then albuminuria category we have 3 stages. We have A1 to A3. Looking at GFR stages, we have to appreciate that this is the main staging criteria. So we have the stage 1, stage 2, stage 3A, stage 3B, stage 4, stage 5. So in stage 1, looking at the GFR levels, we are saying here you find that the GFR level is normal or increased. Remember the normal GFR is between 90 to 120, okay? So it will be normal or it might be increased, okay, in stage 1. In stage 2, the GFR is mildly reduced, okay, so that will range from 60 to 89 mils per minute. Stage 3, we have it's subdivided into 2. Of course, all of them have moderately reduced, but in terms of GFR ranges, we're saying that for the 3A, we have 45 to 59 mils per minute, whereas the 3B, we have the 430 to 44 mils per minute. Stage 4 is when the GFR is severely reduced, and this will be between 15 to 29 mils per minute. We have the kidney failure. Kidney failure is the stage 5, and the stage 5 is when the GFR level is less than 15 mils per minute. Good, guys. I have a quick one here. A 55-year-old male patient is diagnosed with chronic kidney disease. The patient's recent GFR was at 25. What is the stage of chronic kidney disease is this known as? 25, guys. 25 is what? Stage 4, right? Stage 4. Very good. Very good. A patient with stage 4 asks which type of diet they are supposed to follow. You explain to the patient should follow which type of diet. What about protein, guys? Stage 4 should be low protein, okay? Low protein. We don't want more wastes, okay? Makes B automatically wrong, okay? Wrong. What about sodium? What do we need? We need low sodium, guys. We need low sodium, guys, okay? So that's why it makes what? It makes C wrong. So we are remaining with A and B. Let's move on. What about potassium? A and B. We both need low potassium, yeah, because potassium has been accumulating and we know the effects of potassium it has. What about phosphate, guys? Phosphate. We are saying that phosphate is normally there in higher levels. We will not want it in high levels, and that makes it D wrong, okay? So for a patient with stage 4 type of chronic kidney disease, we need low protein, low sodium, low potassium, low phosphate diet. Great. So we have the albuminuria stages of CKD, and albuminuria we have stage A1, A2, A3, and in this case we are comparing the albumin to creatinine ratio, okay? The normal one should be less than 30. So you find in stage 1 this patient with CKD will be having less than 30 milligrams in 24 hours. But in A2, albumin category stage 2, the ratio, albumin to creatinine ratio, will be between 30 to 300 milligrams in 24 hours. Final stage, which is the most severe form, you'll find that the ratio, the albumin to creatinine ratio, will be greater than the 300 milligrams per 24 hours. Ladies and gentlemen, we can classify chronic renal failure based on the causes, based on the GFR, and based on level of albumin in blood. The most recommended one is the GFR with the 5 stages. Okay? Thank you so much. What about the pathophysiology? You say that the pathophysiology of chronic renal failure is saying that we have nephron destruction. Nephron destruction, the basic unit of the nephron of the kidney, is destroyed, eventually leading to irreversible kidney damage. So disease may progress through the stages based on the GFR, causes or degree of albuminuria. Okay, so all these causes are going to eventually result in nephron destruction, be it hypertension, endocrine diseases such as diabetes, glomerular disease, especially if it's primary or secondary, congenital anomalies such as polycystic kidney disease, kidney damage, vascular disease, cystic kidney disease, acute kidney injury. Okay? In terms of risk factors, as you can guess, family history will pose a risk. Chronic infections such as chronic pyelonephritis. Remember, we are looking at UTI and we came up with pyelonephritis. If you've forgotten, you can check the link on UTI so that you can see how they are related. We also have collagen diseases, and these collagen diseases include the systemic lupus erythematosus and scleroderma. They do contribute, pose a risk for developing chronic kidney disease. Nephrotoxic drugs that we had talked about, especially antibiotics such as aminoglycosides, chemotherapeutic agents, we had talked about them. Obstructive processes such as calculus, okay? Remember we have a link on the renal calculus. Check and find out more. Vascular diseases such as endocarditis, heart diseases, elevated cholesterol levels, obesity, smoking, renal artery stenosis, use of illicit drugs such as heroin, and the elderly age more than 65 are likely to develop this condition. Just to test your risk factors, guys, which patient is not at risk for developing chronic kidney disease? A 58-year-old female with uncontrolled hypertension? This one? At risk, right? Great. A 69-year-old male with diabetes? Yes, diabetes, hypertension, all are risk factors. What about C, a 45-year-old male with polycystic ovarian disease? It should be polycystic kidney disease, okay? Ovarian is very distant from it, okay? So 78-year-old with intrarenal injury. Yes, that one can contribute chronic kidney disease, okay? So polycystic ovarian disease may not be included in that matter. A patient with stage 5 of CKD is experiencing extreme pruritus and has several areas of crystallized white deposits on the skin. As the nurse, you know this is due to excessive amount of which substance found in the blood? Urea, very good. Urea, okay. So this patient is experiencing uremic frost that occurs in severe chronic kidney disease, okay. This is normally due to high amounts of urea in blood being secreted by the sweat glands into the skin and which will appear as white deposits on the skin, okay. The patient will experience itching with this as well, okay. Incidence. What is the incidence of CKD? We're saying that CKD affects 1 in 10 adults in the United States. Okay, the disorder can occur at any age, but the most common is the elderly. Okay, we have the highest incidence over age 60, so more males than females will require hemodialysis. Complications. We have anemia. Why anemia, guys? Yes, the kidney is responsible for the production of erythropoietin, which is very important in the process of blood formation. So when it's not there, we are going to result with anemia, okay? Okay, great guys. So the other complications include hypertension, cardiovascular diseases, hyperparathyroidism, especially the secondary form, yeah, peripheral neuropathy, lipid disorders, platelet dysfunction, pulmonary edema, pericarditis, electrolyte imbalances, sexual dysfunction, malnutrition, renal bone diseases, renal osteodystrophy, decreased immune response, end stage kidney disease, stage 5, right? And finally, the one that we fear most, death. Yes, guys, a patient with CKD has a low erythropoietin level. The patient is at risk of which complication? Anemia. Very good, guys. Guys, you're doing great, okay? And we need to keep up with that. So when you're looking at the assessment, in assessment we are interested with the interview that we had with the patient to get the history and the physical examination that we'll do to find to get the physical findings. So when you look at the history, the report from the patient, we say that usually there is no signs and symptoms until stage 4. Remember we said that until 75% of the GFR is lost is when now the patients can be able to show the signs and symptoms. So history of underlying disease, the patient could say maybe I've been having hypertension, I've been having diabetes for this number of days and blah blah blah. So you get there. Dry mouth, okay, present with dry mouth, fatigue, nausea, vomiting, anorexia, hiccups, muscle cramps, weakness, headache, twitching, yeah, muscle cramps because of what? Hypocalcemia. Very good, guys. What about pruritus? Accumulation of waste, right? Thank you so much. So the other history will include infertility, decreased libido, amenorrhea, erectile dysfunction, pathologic fractures, sleep problems, change in urine output, shortness of breath, chest pain, peripheral edema, new onset of heart failure, and bleeding tendencies. Okay. What about the physical findings? Remember, you have to for you to get the physical findings, you have to inspect, okay, palpate, percuss, and auscultate. So you're going to have decreased urine output, okay? Remember, the patient is supposed to have at least 30 mils per hour, okay? Great. Hypertension, altered level of consciousness, and this can be elicited through the carrying out the general survey, getting to know the time, place, and person, okay? or AVPU or GCS during the comprehensive assessment. Peripheral edema, cardiac arrhythmias, basilar crackles, pleural friction rub, gum ulceration, and bleeding. Okay. We also have the gum ulcerations and bleeding. We've already said. Signs of malnutrition, loss of lean body mass, uremic factor, abdominal palpation on anterior nasal palpation, poor skin texture, pale yellowish bronze skin, thin brittle fingernails, and dry brittle hair are some of the findings you're going to get on this particular patient. What of the diagnostic tests? In diagnostic tests, we are going to look at two. We'll have laboratory and imaging. When you start with laboratory, say that GFR may be normal or decreased. Okay, of course, we have already stated that the normal GFR is 90 to 120 mils per minute. Okay. Also in laboratory, you're saying that we look at the albumin to creatinine ratio or albumin excretion rate. So we find that it may be normal or increased. Remember the normal value we said it should be below 30 milligrams. Blood urea nitrogen BNU level test will show elevated levels of what? Creatinine, yeah, as well as sodium, potassium, phosphate, and ammonia levels. When you look at arterial blood gases, will show decreased pH, okay, pH and bicarbonate levels. So the patients will likely to be having metabolic acidosis. We have hematocrit test and hemoglobin level test result are low. Okay, red blood cell survival time decreases. We have mild thrombocytopenia and platelet defects appear. Aldosterone secretion is increased. Okay, remember this one is just compensatory mechanism. The patient will always be having hypocalcemia, so aldosterone increase just to replace some of this calcium that has already bound to phosphate. We have hyperglycemia and hypertriglyceridemia may occur. Okay, high density lipoprotein levels are decreased, and urinalysis reveals proteinuria, glyceria, and urinary RBCs, leukocytes, cast, and crystals. Looking at the second one is imaging, and on imaging you're saying you're doing the Coombs radiography, excretory urography, and nephrotomography. This one may all show reduced kidney size. Remember, this is another difference between acute and chronic. Okay, in acute the kidney size may not be really affected. Here the kidney size will reduce in size. We also have ultrasonography, which may reveal hydronephrosis, small kidneys, and other structural abnormalities. Renal angiography. Renal angiography may identify renal artery stenosis. Computed tomography scanning may identify renal vein thrombosis, kidney masses, or cysts, as well as kidney stones. What about magnetic resonance imaging, MRI? It may be performed for patients unable to receive the IV contrast. Lastly, retrograde pylorography may identify obstruction and renal calcule. What are some of the diagnostic procedures these patients are likely to undergo? We are going to have kidney biopsy to identify the underlying pathology, and we'll have electroencephalography, which will show changes suggesting metabolic encephalopathy. And that's why patients will be presenting with confusion, with the neuro changes, courtesy of those accumulation of those wastes. Very good. Looking at treatment, guys. In treatment, we're going to have several sections. We'll be looking at general treatment, diet treatment, activity treatment, medication treatment, and surgery intervention, and lastly, nursing interventions. Starting with the general treatment, we're saying will be treatment of the underlying cause, the cause of the problem. Avoidance of factors that may increase progression of kidney dysfunction. Control of hypertension and diabetes. Smoke cessation. Okay. Weight reduction in patients who are overweight or obese. And then venous thromboembolism. Yes, prophylaxis if the patient is hospitalized. Those are the general treatment for a patient with CKD. On diet, as we have slightly or a number of occasions mentioned it, the patient should have low protein, okay? Low protein with peritoneal dialysis, high protein, okay? High calorie, low sodium, low phosphorus, low potassium diet, okay? We also have sodium and fluid restriction, okay? Sodium and fluid restriction and protein restriction for stage 5. Remember, we're talking of low protein for the other stages, but stage 5 you have protein restriction, okay? And this is based on the serum protein and albumin levels. On activity, we are saying that we should have rest periods when the patient is fatigued, okay? Yes, very good. What about medication? Medication, we have a number of medications that we need to know. We are saying that acute angiotensin converting enzyme, ACE inhibitors, yes, or angiotensin receptor blockers are normally used to control hypertension and the progression of proteinuria. Anti-diabetic agents are used to control glucose levels. Phosphate binders, such as calcium carbonate or calcium acetate, are used when the patient is experiencing hyperphosphatemia. Oral calcium carbonate and calcitrol, are used when the patient is experiencing hypocalcemia. We also have epoetin alpha or gabapentin alpha or iron salts such as ferrous sulfate are used when the patient is experiencing anemia. Okay. We also have statins are used in patients with hyperlipidemia. Okay. Loop diuretics for fluid volume overload unless if the patient has reached stage 5 of kidney disease. We also have the calcimimetic agents such as cinacalcet hydrochloride to reduce parathyroid hormone levels. So what is the role of the parathyroid hormone levels, guys? Parathyroid is to increase the level of calcium in blood. So the sodium carbonate is used to help reduce phosphate levels without inducing hypercalcemia, okay? And this is better over this other. Then lastly, we have use of the analgesic to manage pain. So I have a question here. I have a 65-year-old male client with a glomerular filtration rate of 55 mL per minute. The patient has a history of uncontrolled hypertension and coronary artery disease. You are assessing the new medication orders received for this patient. Which medication ordered by the physician will help treat the patient's hypertension along with providing a protective mechanism to the kidneys? You have lisinopril, metoprolol, amlodipine, verapamil. So guys, C and D can easily be excluded since they are from the same class, okay, and therefore they possess same characteristics. To be precise, these one are normally the calcium channel blockers, okay. Good. What about metoprolol? Metoprolol, these are beta blockers, okay. And remember, in our presentation, we say that the best examples of these drugs are ACE and angiotensin receptor blockers. Okay, angiotensin receptor blockers. So ACE should be chosen over enalapril, lisinopril, and prils. The pril family is good, okay, because it's used to treat hypertension and protect the kidneys with in patients with CKD. Okay, great guys. You are providing education to CKD about calcium acetate. Which statement by the patient demonstrate they understand their teachings about this medication? Need to select all. Calcium acetate. So calcium, the best principle here that we need to have is that we're only working on the calcium ions and the phosphate ions. Okay, so let's go. This medication will help keep my calcium level normal. Okay, calcium is talking about calcium, so we'll keep it for consideration. I will take this medication with meals or after meals, with meals or immediately after meals. It's important I consume high amounts of oatmeal, poultry, fish, dietary products while taking this medication. Patients with CKD, guys, this kind of diet, excessive proteins, not allowed. No, no. This one is a no, no. C is completely out. These medications will help prevent my phosphate level from increasing. This can be kept for consideration. So calcium citrate is a phosphate binder that we know. Okay, so it can prevent that. So it will help the patient phosphate from becoming too much. It also helps excrete phosphate taken in the food, okay, by excreting it out. So that means you can easily take it with what? With food, so that it can bind there, okay. So therefore it should be taken with meals or immediately after meal, okay. Option C, we have already ruled it. Out, okay. So this medication can assist, can help calcium level normal. Medication should be taken with the means because it will bind to the phosphate and excrete immediately, and this medication will also help prevent phosphate from rising. So the type of procedures that these patients are likely to be involved in with the hemodialysis and peritoneal dialysis, whereas the surgery will be the creation of access for dialysis, okay, where it is matures, whatever, and then lastly the kidney transplant also as another intervention. In terms of nursing interventions, we simply give the independent and the dependent. The independent ones are where the nurse can carry on without necessarily the input from the other cadres. The dependent ones will depend on the other cadres, including physician, nutritionists, lab techs, counselors, and all the other available healthcare providers. So in the nursing interventions, you need to give prescribed medication, okay? Administer ACE inhibitors as prescribed by the physician so that you can control hypertension, okay? You give a phosphate binder with meals, okay, because it's going to bind in the phosphate in the meals, and you give oral calcium carbonate without food. With calcium, with no food, but if it is phosphate, you give it with food, okay, you give it with food. So the challenge here is to understand that calcium acetate is a phosphate binding, okay, that is the challenge, okay. So that means you can easily give it with food. If you didn't know that, then you can easily skip option B, okay, fearing the food chemical interaction. You also need to administer subcutaneous epoetin alpha, okay. This is normally done weekly as ordered, so that or give double poetin alpha V or subcutaneous as ordered. You encourage the patient to express feelings and concerns, especially related to the effect of the illness on the family members, sexuality, and the patient roles, provide emotional support, and encourage the use of positive coping strategies. You provide clear explanation of all care and treatment. You encourage the patient to participate in decision making as much as possible to promote feelings of control over the situation. Expect dosage adjustment for medication cleared by the kidney. You need to obtain daily weight, not any significant increases or decrease, and report the findings to the physician. Check the patient hydration status and avoid volume depletion or overload. You need to insert an indwelling catheter as ordered and as indicated to evaluate urine output. Check urine output hourly if the patient is in critically ill. Remember, the patient has to have an output of at least 30 mils per hour. Screen for and assess patient's pain using the facility-defined criteria that is consistent with the patient's age, condition, and ability. Some facilities will have the OPQRST, others will be having the SOCRET. You use appropriately. Treat the patient's pain as needed and ordered using the non-pharmacological, pharmacological, or a combination of these approaches. You need to monitor closely if the patient is in high risk for adverse outcomes related to opioid treatment if prescribed. Reassess and respond to the patient's pain by evaluating the response to treatment and progress towards pain management goals. Remember to provide frequent rest periods, especially when the patient is tired, okay? Cluster the activities to promote rest. Apply anti-embolism stockings or sequential compression stockings to prevent the thromboembolism. Okay, very good. Assist with care measures as appropriate. Encourage the patient to participate in the care and encourage the use of energy conservation techniques to minimize energy expenditure and prevent fatigue as the most commonly reported symptoms. Institute bleeding precautions if the patient's platelet level is decreased. You need to inspect the skin and the mucous membrane for signs of bleeding, such as of ecchymosis, bleeding under the skin. Okay. Auscultate the heart and the lung sound for changes, and then institute continuous cardiac monitoring if the patients exhibit electrocardiogram changes like peaked T waves, wide QRS, and prolonged PR intervals. You need to provide skin measures, okay, including measures to reduce pruritus as appropriate. Remember, the pruritus is because of the urea wastes, okay? So give the measures, okay? Encourage the patient to shorten the nails, okay? Avoid scratching and take care of the infection that may arise as a result of the scratching. Assist with maintaining fluid restrictions, provide the prescribed diets, okay? Remember, in early stages, we are giving low protein. In late stage 5, we are restricting protein. Check the patient's level of consciousness for changes, general survey, AVPU, or GCS, okay? Obtain specimen for laboratory testing such as urinalysis, serum electrolyte levels, creatinine clearance as indicated. Prepare the patient and family for possible kidney transplant or dialysis. Then provide care for the dialysis access a site as indicated. Okay? Great. Remember to be feeling for the thrill and auscultating for the bruise. Okay? Great. Provide pre-dialysis and post-dialysis or pre-transplant care as required depending on the intervention of the surgery procedure that has been implicated or indicated for that client. What do you need to monitor? Monitor kidney function studies, vital signs, input-output, daily weight, fluid balance, hydration status, nutritional status, the coping, cardiopulmonary status, laboratory test results, especially electrolytes and blood, urea, nitrogen, and creatinine levels, signs and symptoms of bleeding, dialysis access site, pre-dialysis, post-dialysis status, and post-transplantation status. We have associated nursing procedures. You're going to be giving the anti-embolism stockings application, that is the knee length, okay, or the thigh length. You're going to assist in clean catch, okay, for the females and the males. You're going to assist in hemodialysis and arteriovenous access monitoring. You need to look hemodialysis and the double lumen catheter. You need to support in getting the informed consent. Remember, the patient needs to be explained the procedure before the consent is gotten from the client. Monitor the intake input measurements, IV bolus injection, IV catheter insertion, IV catheter removal, IV pump use, IV secondary line infusion, nutritional screening, oral drug administration, pain assessment, pain management, peritoneal dialysis, okay, and then safe medication administration, and lastly sequential compression therapy, okay. Those are some of the associated nursing procedures for patient with CKD. What about the patient teaching? Okay, guys, remember during patient teaching you need to include the family, the patient's family or caregiver in your teaching as appropriate. Remember to provide information about according to the patient needs, okay, both learning and communication needs, and be sure to cover several aspects regarding the disorder, diagnostic testing, treatment, including the possible need for kidney transplant if indicated. Remember to also include the prescribed medication regimen, okay? Include the drug's name, dosage, rationale for use, frequency of administration, expected result, duration of therapy, and any side effects, if any. Need to take oral calcium carbonate without food, but to take a phosphate binder, okay, or the saline carbonate with meals, okay. Need to work or teach also on the pain management plan and potential adverse effects of pain management treatment. You need safe use, storage, and disposal of opioids if prescribed. Also, the importance of adhering to the schedule for certain laboratory tests, such as blood and urine chemistries and the GFR. Recommended diet for these patients also need to be made clear, such as one high in calories, low in sodium, low in phosphorus, low in potassium, and appropriate food choices and foods to avoid. You need also to talk about the signs and symptoms associated with electrolyte imbalance, danger signs to be reported immediately to the healthcare provider. Fluid restrictions, including the amount allocated, okay, and how to divide it in the course of the day. Importance of adhering to dialysis schedules, including teaching about the complications, okay, that can occur if dialysis treatments are skipped. Dialysis site care as appropriate, techniques for home dialysis if appropriate, and if the patient is on dialysis, okay. Also the signs and symptoms of infections at the access site and the need to notify the healthcare provider if they occur. The nurse also needs to talk about the importance of wearing or caring for medical identification, okay. So the patient needs to wear and also carry that medication identity card, okay. Also the signs and symptoms of complication related to dialysis or of possible organ rejection as appropriate, and the need to immediately notify the healthcare provider if occurs. In discharge planning, you need to participate as part of the multidisciplinary. Remember, during the discharge, you need the input of all the healthcare personnel. You need the nurse, you need the care manager, you need the social worker, the nutritionist, urologist, nephrologist, and the primary healthcare provider in coming up with the plan. Remember the plan, the patient must be included so that they must be able to participate fully. So you assess the patient and the family understanding of the diagnosis, the treatment, the follow-up, the warning signs, which will warrant them to seek for medical attention, okay? It must be there. Assess the patient's individual level of independence before admission. Okay, that can inform whether to be discharged home, whether to be discharged in a palliative home, oncology home, and so on and so forth. Evaluate how the current illness will affect the patient independence. The patient needs to be told, because of your current illness, this is going to be affected, so you have to understand and take some time to get over it. Yeah. You need to identify patient informal and informal supports. Remember, these are the key when helping the patients, okay? In case of any emergency, the patient is able to be assisted with these supports. The support system is important for recovery. Identify the patient's and family goals, preferences, comprehension, and concerns about the discharge and need to be addressed. Confirm arrangements for transportation to the initial follow-up appointments. You need to provide a list of prescribed drugs, including dosage, prescribed schedule, adverse reaction to report to the healthcare provider. Provide the patient, yeah, with written information on medication that the patient should take after discharge. Yeah, you have to write down. You're going to take 1, 2, 3, 4. Yeah, good. Assess patient and family understanding of each prescribed medication, including the dosage administration, expected result, duration, and possible adverse effects. Assess the patient's ability to obtain medication. Identify the party responsible for obtaining the medication. Instruct the patient to provide a list of medication to the healthcare provider who will be caring for this patient upon discharge. Okay. Remember to update the information with the healthcare provider. Okay, on the medication that are supposed to be used, discontinued. We should try to discourage this idea where the patient is having several prescriptions from different healthcare providers. This one needs to be reconciled so that all the healthcare providers know the every type of medication that the patient is using. Assess the patient's ability to attend dialysis session as prescribed. How many sessions a week? Yes. Ensure the patient and caregivers receive medical contact information. Assess the patient's and family understanding of teaching by using the teach back where possible. Okay, you do an activity, the patient does a return demonstration. Okay, so that you are able to know if they are getting it. Refer the patient and family to local support groups if indicated. Ensure that the patient or the healthcare provider receives a copy of discharge instructions and that a copy is placed in the patient medical record. Remember to document the discharge planning evaluation in the patient's clinical record book, including who was involved in the discharge planning and teaching, and the understanding of the teaching provided, and any needs for follow-up upon teaching. Okay? Very good, guys. Very good. Thank you so much, guys. We've come to the end of our session. We thank you so much for getting involved in our lecture. Kindly go through our presentation and we can get the feedback. Otherwise, thank you so much. Have a good time. Thank you all. Thank you so much. Okay.